Hi, everyone. It's a pleasure being here with you all today, and thanks to the organizers for having invited me. Today, I'll be speaking about what can be done from a community perspective to improve the well-being and quality of life of people as they live longer lives and age with HIV. Next, my disclosures. The HIV population is a population which is becoming increasingly older. This is, of course, the result of people living longer thanks to effective treatment, but also the result of the number of new diagnoses in people aged over 50. In high-income countries, the percentage of people living with HIV over the age of 50 has increased rapidly, in many cases to over 50%. And the same trends will be seen in middle and low-income countries in the future, with a high prevalence of comorbidities in this age group. And let's keep in mind that late presenters represented 53% of those diagnosed with HIV in 2019 in the European region, and that a great proportion of these are people aged over 50. So it's not just a demographic change, but something that will require a radical change in clinical approach and a challenge for the social welfare system. WHO defines healthy aging as the process of developing and maintaining the functional ability that enables well-being in older age. And functional ability is about having the capabilities that enable all people to be and do what they have reason to value. In turn, functional ability consists of the intrinsic capacity of the individual, the relevant environmental characteristics, and the interaction between the two. The traditional approach to aging in people living with HIV is focused mainly on monitoring chronic comorbidities in older individuals. It is disease-centered, and it focuses on measuring an individual's health deficits at a later stage in life where little can be done to prevent the decline in function. And it overlooks that the process of aging with HIV is multidimensional, and that in addition to the impact on biological systems, there are many other factors which may shape the process of aging, often at an earlier age. WHO's model for healthy aging proposes a life course approach to aging, encouraging policymakers and health professionals to look beyond disease and approach aging as a process to maximize an individual's functional ability, and optimizing two components throughout an individual's life: their intrinsic capacity and the external environment, represented by the social determinants of health. The strong interplay between these two components is often overlooked in our clinical approach to aging, which on the contrary is important because the external environment can help balance and compensate for losses in intrinsic capacity and help maintain function. This life cycle approach has been highlighted by the EATGs through its Aging with HIV project, which has identified key areas and recommendations for policymakers, clinicians, and community for each specific age group, and was highlighted by Linda Gale Becker at this year's IAS conference, where she emphasized the increased rates of geriatric syndromes and frailty among people aged over 50, but also among the younger age group of people having contracted HIV at birth or at a younger age. A recent study presented at CROI last year suggests that comorbidity-free life expectancy for people living with HIV was 13.3 years compared to 29.3 years for HIV-negative individuals, with a 16.1-year gap and no improvement seen even with early ART initiation. On the right, you can see data from a recent study based on the Italian ICONA cohort, showing a significant prevalence of morbidities in all age groups and a significant increase over a 10-year period compared to the general population. The Italian data is in line with similar findings from other studies. We're talking about an increasingly older population experiencing an increasing number of comorbidities. Therefore, the prevention, treatment, and management of comorbidities has become a key element of HIV care. What is needed is a greater use of preventive medicine in preventing, delaying, and mitigating morbidities, early screening and treatment of comorbidities, a regular assessment and management of polypharmacy and drug-drug interaction, a greater engagement of patients in their healthcare and better self-management skills, rehabilitation services for those frail and disabled, and a focus on tailoring HIV treatment, matching patients' needs to treatment options available. And regarding early screening and treatment of comorbidities, there's an interesting recent real-life study in France on the diagnosis and management of diabetes in people living with HIV. The study shows how diabetes is underdiagnosed and undertreated in almost 20% of this population in France, and that the diagnosis of diabetes was missed in 37.8% of participants in the study, and 47.2% of those treated did not reach the desired levels of glycated hemoglobin, less than 7%. The authors therefore suggest that screening for diabetes should be carried out at a substantially earlier age for people living with HIV compared to the general population, possibly 10 years earlier, and that the therapeutic management of diabetes should be strengthened. We all know that HIV care will routinely intersect with geriatric medicine, and the CGA, or Comprehensive Geriatric Assessment, is a total patient model suitable to address a comprehensive, coordinated care in people living with HIV. Recently, the Italian guidelines for HIV care have included a section dedicated to the management of aging and frail HIV patients, in which assessments of frailty and comprehensive geriatric assessment are recommended. Scope of geriatric care is that of preserving functional status and therefore avoiding geriatric syndromes. And people living with HIV can certainly benefit from these care models, which are focused on managing multimorbidity through a multidimensional approach. In fact, the assessment of morbidities alone does not reflect the complexity of aging as a health condition. Two people with the exact same comorbid conditions can have very different functional capacities. The geriatric model focuses on conditions such as frailty, cognitive impairment, compromised mobility, risk for falls, and polypharmacy, and is aware of the impact of social isolation and mental health on health outcomes. It places emphasis on personal responsibility and self-efficacy. For example, in the management of medication, in avoiding falls, in optimizing nutrition, and in engaging in exercise programs, and is aware that an empowered patient interacting with care providers can achieve the best health outcomes possible. However, the majority of existing guidelines do not include formal assessment of geriatric conditions. Many aspects impacting the well-being and daily lives of people living with HIV are often not identified and discussed during clinical consultations. Often priorities of patients and healthcare professionals do not coincide, and sexual health and mental health are aspects often overlooked and underestimated during clinical consultations. Interesting to see some findings from the Positive Perspectives Wave 2 study, indicating that 53% of treatment-experienced people living with HIV over the age of 50 had difficulties in raising concerns with their healthcare professional, and 84% of newly diagnosed aged over 50 experienced the same problems. Many speakers at IAS this year have highlighted the potential of patient-reported outcome measures, which are tools in the form of questionnaires able to capture the patient experience in many domains, and which have the potential of enabling and facilitating communication between patients and healthcare professionals, offering our doctors the opportunity of knowing their patients better, what matters to them most, what barriers they may face in their daily lives and in their healthcare, and offers patients an opportunity to openly discuss in the course of consultations those issues and concerns which for many reasons they are often unable to express during consultations, empowering them to actively take part in the conversation, in joint priority setting, and in shared decision-making on interventions to bring forward. If widely used, patient-reported outcomes can be indeed a key element of patient-centered care. Frailty is defined as a clinical condition of increased vulnerability associated with a decline in reserve and function. Disability and frailty have become new challenges as people aging with HIV experience higher levels of multimorbidity, with specific needs and vulnerability, as well as deficits in functional capacity and ability to perform daily activities. Specific to elderly people living with HIV, frailty is a key contributor to psychosocial challenges such as isolation, loneliness leading to depression, decreased ability for self-care, decreased working capacity, and poor quality of life. Resilience, on the other hand, is a characteristic at both physical and psychological level, which determines an individual's ability to resist functional decline or recover physical health following a stressor. It is a multidimensional concept which seeks to explain how some individuals can attain, maintain, or regain well-being in the face of hardship. There are many studies providing evidence suggesting a possible relationship between high levels of resilience and overall well-being, and that resilience may indeed be a protective factor against the development of disability, chronic illness, depression, or low health-related quality of life. In people living with HIV, high resilience was related to a lower prevalence of depression, anxiety, and problems with activities of daily living, and was also associated with lower internalized stigma. So what is needed are multi-level interventions that can promote resilience among people living with HIV, incorporating interventions to reduce internalized stigma and promote supportive environments, including well-structured referral systems to support services within the local territory. Health literacy and targeted interventions can enable patients to develop self-management skills, especially as they grow older. For example, in the management of medication, especially in those poorly-treated, in optimizing nutrition, in stopping or limiting smoking or alcohol or drug use, in engaging in exercise programs, in managing stress, and in keeping oneself mentally and socially active. And this takes us back to the WHO framework for healthy aging, in which we can clearly see many of the concepts we've been talking about. Prevention, early screening and control of morbidities, the possibility through appropriate interventions of reversing or slowing down declines in capacity, or that of managing advanced conditions, that of supporting capacity building and self-care, and that of promoting healthy living behaviors and addressing social determinants to compensate for loss of capacity. Here are some recommendations in what community-based organizations can do to support healthy aging in people living with HIV. Initiatives empowering patients to take on a more proactive attitude towards their health through changes in lifestyle and enhancing self-management skills and self-efficacy. Initiatives empowering patients to actively engage in the therapeutic relationship with their healthcare professional, leading to joint priority setting and shared decision-making. Initiatives providing peer professional support in identifying and developing appropriate strategies in addressing psychosocial and relational problems that may emerge from the HIV status or from the aging process, such as self-stigma, loneliness, and social isolation. Peer-led initiatives providing social support to people in conditions of frailty and disability, and finally, initiatives aimed at resilience building. Some final considerations. People living with HIV have been impacted by COVID-19 in their physical, mental, emotional, and social spheres, with unclear consequences in the long term, especially for older individuals with greater vulnerabilities. Service disruptions and continuity of care in times of emergency have led to a distancing from care, with many people adapting to fewer visits and fewer contacts with clinics, with the risk that what we've lost to COVID may somehow become the new normal. With the limitation of screening services and specialist visits, there has certainly been an impact on comorbidities, which may lead to undiagnosed, untreated morbidities, which can be particularly relevant for older individuals. And as we move forward towards a new normal, the concept of healthy aging and quality of life should guide us all in our daily work and at all levels, at policy level, at clinical level, and at community level. And as we have seen in an earlier presentation, people living with HIV are disproportionately affected by mental health problems, which are often underestimated in clinical practice. And COVID has certainly destabilized people living with HIV in many ways. And finally, community-based organizations have historically played an important role in supporting people suffering from depression, loneliness, and internalized stigma, and can certainly play an important role in promoting healthy aging in their community. Thank you all for your attention and your patience.